Good morning. I'd like to say thank you to all you folks that are working for these kids. It means so much to us as parents. I know especially it does to us. My name is Rhonda Harris. I'm here with my husband, Don Harris, and we have two children. We won the lottery. We have two with TANGO2. So Michaela is 28. She'll be 29 in September. And Seth is 13. As you can tell, we're from Southeast Georgia, that little... Okay. I'm going to introduce the next speakers. It says our next speaker is Dr. Claudia, I hope I pronounced this right, Cellular Alfonso, and Kevin Glinton come to us via pre-recorded video. Dr. Cellular Alfonso is an assistant professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. She completed her combined pediatrics and genetics residency training at the University of Texas Health Science Center in Houston and a fellowship in clinical biochemical genetics at the Children's Hospital of Philadelphia. She is board certified in both clinical and biochemical genetics. Her professional interests include studying metabolic disorders of glycogen, lactate, and pyruvate, as well as development of novel therapies for metabolic defects of energy generation. She manages metabolic problems in children with TANGO2-related disorder. Dr. Glinton is an assistant professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. He completed a residency in pediatrics at the University of Virginia Health System and then fellowship in clinical genetics and clinical biochemical genetics at Baylor College of Medicine. While at Baylor, Dr. Glinton's research has focused on the clinical applications of untargeted metabolics as well as the characterization of rare neurometabolic disorders. Dr. Glinton is involved in several clinical trials in rare genetic disorders and enjoys educating students and patients on genetics and genomics. Here is Dr. Cellular and Glinton via pre-recorded video.
All right. So good afternoon, everyone. I'm Kevin Glinton, assistant professor at Baylor College of Medicine. Today I'll be presenting our recent work on the assessment of metabolic studies in TANGO2-related disorder. And so briefly, I'm going to talk a little bit about the background and rationale for this work, why we decided to look at these assays. We'll talk about the results of our analysis of the metabolic testing, and then we'll give you an idea of the next steps or the future direction that we may be able to go into with your assistance. So let's start with talking about metabolic disorders themselves. So metabolic disorders are diseases due to any abnormality in a biochemical pathway in the body. And so that can be any number of different things. There can be differences in the way someone processes a particular component from food, like a problem processing fats or carbohydrates. You can have an inborn deficiency or inability to metabolize a certain nutrient or vitamin that leads to a deficiency. Or you can have an inability to break down a specific chemical from the body or in the body. Certain disorders where people have difficulties breaking down the linings of nerves, for example, that can cause a metabolic disorder. Whenever we have metabolic disorders or metabolic diseases, we often collect a lot of biochemical testing. And these are just laboratory tests that help us identify the underlying defect or mechanism of the disease. They, in the past, have been the primary means of us making a diagnosis, but they're also helpful moving forward now that we have genetic testing in giving us signs of crisis or when a patient is about to get sick or when they are sick, the severity of their illness. These tests are also very important in helping to us identify areas where we can assist in the treatment of diseases. But it's important to know with these types of tests that they are heavily influenced by the underlying nutritional status of the patient. So we commonly, and we will often see differences in a patient's test based upon what they've eaten, when they've eaten, what kind of medications or nutrients or supplements they're taking, etc. Why is this important for us? Well, we think of TANGO2 as a metabolic disease, and we usually obtain biochemical testing in patients with TANGO2 after you've made a diagnosis or when patients are in a crisis or recovering from a crisis. We think of it this way because TANGO2 appears very similar to disorders of fatty acid oxidation. And these are a particular type of biochemical or metabolic disorder where the body has difficulties breaking down the fats that we take in from food or the fats that we make. As you can see on the diagram on the right, this is a complicated process that relies on different enzymes and pathways and cofactors. And so there are any number of fatty acid oxidation disorders that can affect one's ability to break down fats from food. But we say that TANGO2 looks like these because of the crises themselves and how similar they are to well-established fatty oxidation disorders. Crisis in TANGO2, for example, correlate with fasting and poor feeding, similar to what we see in some fatty acid oxidation disorders. In crisis with TANGO2, you'll see low blood sugars or hypoglycemia. You'll see high lactates, high ammonia levels. And you will commonly see in more severe crises, muscle breakdown or cardiac rhythm abnormalities. And that's very, very similar to what we see with classical fatty acid oxidation disorders. So in our current study, we were trying to identify a particular biochemical pattern that we could say is specific for patients with TANGO2. And that would allow us to make better diagnosis or earlier diagnoses to better be able to manage patients and to design, specialized and more effective therapies or treatments for patients. And so in doing this study, we looked at the results of the following tests or biochemical tests, both at baseline and at crisis in patients with TANGO2-related disorder. So we looked at plasma amino acid analysis, we looked at acyl carnitine profile analyses, and then we also looked at urine organic acid analyses. And many of you may have had one or all three of these tests performed, but we'll go through each one about what, in terms of what they assess for and what we can learn from them before we talk about our results. So our first test is our plasma amino acids, and this is a test we commonly get as metabolic physicians on a lot of our patients. The assay itself varies widely in terms of how many amino acids we could measure in blood. You can have some labs that perform an analysis of only the 20 sort of core or basic amino acids, and others that measure upwards of 40 or 50 amino acids. Essentially, plasma amino acids allow us to look at a person's baseline nutritional level and the way that that person is processing proteins, because we get amino acids from our protein intake. You can also get amino acids from other nutritional sources, but we primarily use it to look at protein metabolism and sort of your baseline nutritional level. In terms of metabolic disorders, we use plasma amino acids to diagnose amino acid metabolism disorders, so problems in the way the body is processing a single amino acid. Disorders like phenylketonuria or PKU, or other disorders like maple syrup urine disease you may have heard of. We also use plasma amino acids to help us diagnose and monitor disorders like urea cycle disorders, where people have difficulties with their ammonia levels. We will see certain markers that we follow. But it's useful for many other disorders, and we use it commonly whenever someone's on a diet to make sure that their nutrition is meeting their body's needs. The next test is plasma acyl carnitine profiles, and in this test, we measure different fat species in our blood. So as I mentioned, when we eat fats in our diet, they have to be broken down. And fats are made of long chains, and they're broken down into different size chains as your body moves that fat through its metabolic pathway. So we can see different chains being abnormal or normal in certain disorders. And we can also follow the chains in terms of assessing someone's baseline fat intake and their diet. Primarily, we use this test in terms of disorders to diagnose mitochondrial fatty acid oxidation disorders. But we can see differences or specific patterns in certain organic acidemia, so problems in the body's where it may produce a certain acid species. And you may see subtle differences for certain amino acid disorders even. The last test that we looked at were our urine organic acids. And this is where we sort of look at the concentration of water-soluble, non-amino or amine-containing compounds in urine. And even though it's sort of the last on my list, we have been examining urine as physicians for centuries. It tells us so much about a body's functioning. We, to this day, still use this particular test to look at a person's baseline nutrition in general and overall health. But we've learned that it can also tell us about certain enzyme or transporter deficiencies, ways in which the person's body is not getting rid of certain substances or getting rid of too much of a certain substance. So we use organic acids in our urine to diagnose amino acid disorders, fatty acid disorders, nucleotide disorders, many, many, many more. So we can learn a lot from our urine. And so those are the three tests that we looked at in our study. We looked at a total of 88 assays, 38 plasma amino acids, 33 acylcarnitine profiles, and 17 urine organic acids. And we broke them up into baseline and crisis within those subgroups. So first, let's talk about our plasma amino acid analysis. We collected assays from 17 patients, and we overall looked at 38 different or unique amino acids measured in these 17 patients. There was no overall specific pattern that we identified, but we did find some mild differences in measurements when we compared baseline to crisis samples. Though I will say that none of these patterns that we found were statistically significant where we could make strong conclusions from them, but they do give us some clues. So first, we looked at what we call our branched chain amino acids, and these are essential amino acids that really are sort of the easiest for us to use as a marker of nutrition. So if our branch chains are low, that tells us that someone is not eating as well, or they're taking too little protein, or they're fasting. And so what we did see is that when we compared patients' amino acids at baseline and at crisis, patients did have mildly decreased branch chain amino acids in their plasma when compared to at their baseline. As I mentioned, this may be due, obviously, to poor nutrition. So if folks are fasting or if their crisis has been triggered by poor nutrition, it's not unexpected for us to see low amino acids or low branch chain amino acids more specifically. But this is a pattern that we saw. We next looked at the amino acids involved in the urea cycle, because patients, as we have already discussed, can have high ammonia levels, and that sometimes points to a problem with the urea cycle. And we saw actually slightly decreased amino acids involved in the urea cycle. Once again, this may be due to poor nutrition in general, but what's interesting is we did not see an elevation in these amino acids that would, that we would normally see in someone who has high ammonia levels. So it doesn't really go along with our thought that these patients should have high ammonias, but it may be due also, or what may be confounding this result is the fact that patients go into crises with poor nutrition. Difficult for us to say for sure. We lastly looked specifically at our concentration of alanine. Alanine is one of the amino acids that can serve as a surrogate for lactic acid in blood, because lactic acid can be converted to alanine when you have a certain concentration of lactic acid. And we, as we mentioned, expect to see high lactates in patients at crisis. And we did see a slight increase in alanine, but this was not broadly the same for every patient. So some patients had normal alanine levels, which would suggest they had normal lactates, which is counter to what we normally expect to see in crises with TANGO2. Once again, though, this is not a perfect relationship, and this did not meet statistical significance. So it's difficult for us to draw definitive conclusions from this, but it's a little bit counter to what we normally expect to see. So next, we'll talk about the acylcarnitine profiles, and we looked at, once again, 33 profiles from 20 patients, and we looked at 45 unique fat species or acylcarnitine species. Once again, we didn't see a specific pattern emerge, but we did see some mild differences from baseline to crisis, though nothing, once again, that was statistically significant. This is a little bit more of a busy bar graph, but you can see here different acylcarnitine species denoted by the letter C and the number. And the number just tells you how long the chain is in that fat species. So C3 has only 3 carbons, so it's a short chain. And C18 has 18 carbons, so that's a longer chain. And you can see in the bar graph that there were mild increases in the short chains of these individuals in our study. So their C3 levels are slightly higher at crisis than at baseline. There's a mild increase in their medium chain. So C8 and C10 in the blue box are medium chain species. There's a mild increase in those from baseline to crisis. And in the green box, you can see those are all longer chain species that have either a hydroxy or OH group or a double bond, like you see in the colon. And those can be specific for certain types of disorders, but in general, these can be elevated or decreased in fasting, in terms of different nutritional statuses, and then also specific disorders. So elevations in C16 colon 1 or CC18 colon 1 or C18 colon 2 could be due to fasting. And that's been something that we've observed before. Because as your body is fasting, it will break down more of the fats of that length to try and get more energy out. We can see elevations in C14OH and C14 colon 1 OH in patients with what we call mitochondrial myopathy, so a problem in their muscles causing muscle breakdown, which, if you think about it, TANGO2 crises look just like that. So that, for us, was a little bit more interesting that you see those species elevated. And in general, you can see this sort of pattern of C14, 14-1, C16-18 elevated in specific fatty acid oxidation disorders like VLCAD, a very long chain, or long chain hydroxy-acyl-CoA dehydrogenase deficiency. You can see this sort of same pattern of elevations from baseline during their times of crisis. Once again, this is really fascinating to us. It didn't reach statistical significance, so we can't be definitive with using this to make any recommendations, but it does confirm for us that there is something going on in our patients with TANGO2 in their fatty acid metabolism. Finally, our urine organic acids, we had less of these assays to examine, but no less important in terms of the information that it showed us. So we looked at assays from 8 patients, and we looked at 95 different species in urine. Once again, highlighting how important urine is and how broadly you can kind of look at a person's metabolism from their urine. We once again didn't find any specific pattern in these patients, but we did see some mild differences once again that have started to clue us into maybe some of the reasons why patients with TANGO2 have the difficulties they do in crisis. So we looked at first amino acid or organic acids critical in the citric acid cycle. And that's an important body pathway in terms of getting energy into our cells and to the rest of our body. And we did see some increases in the organic acids involved in the citric acid cycle when we compare crisis to baseline. This tells us that either these cells are trying to work too hard or trying to get metabolites through that cycle to give more energy, or that they're not working efficiently and they're trying to work that cycle faster to try and compensate. And so we think of these abnormalities as signs of just sort of generalized mitochondrial dysfunction, where there's something going on in that mitochondria, the powerhouse of our cells, that's not quite working efficiently like it should. We next looked at what's called dicarboxylic acids, and these are specific acid species that you see in terms of as metabolites of fats. And so we saw increased dicarboxylic acids, and that can be associated, or it can be a sign or a pattern of fasting, using MCT or medium chain triglyceride oil as supplementation, or once again, as a sign of fatty acid oxidation disorders. So once again, we're getting back to the clues or the sense that TANGO2 really does act a lot like we think it does, like a fatty acid oxidation disorder, even though there's not a specific pattern that tells us how it's acting in that manner. So some general observations we kind of came to from our study is that, once again, there are no significant abnormalities in these patients at baseline, and that there are non-specific differences when we compare their baseline to their crisis samples, though none of those differences are statistically significant when we take a look at it through a stringent statistical lens. There are many observed abnormalities that we can attribute to fasting during a time of crisis, but our abnormalities that we do see also just point to a general pattern of mitochondrial dysfunction and deficient fatty acid oxidation metabolism, which is what we'd expect, but doesn't give us the exact clues about how and why, as I mentioned. Now, I will say our study had a number of different limitations. we did not reach statistical significance, partially due to the fact that our sample sizes, even though this is the largest such study, our sample sizes still are relatively small from a statistical standpoint. So that limits how definitive we can be with our conclusions. We also should note that we had an unequal distribution of baseline and crisis samples. So we had many more samples at baseline, but much fewer samples from patients when they were actively in a crisis or in the midst of a crisis. I should mention, for us, it's not exactly clear if patients' baseline measurements are actually all normal, or if there are subtle differences between TANGO2 patients and healthy age-matched individuals, both at baseline and at normal nutrition. And that's important because if these patients have subtle differences at baseline, that may tell us a little bit about what is exactly triggering their crisis or what we can be addressing to help prevent crisis in the future. We also should note that the labs we looked at were obtained from many different laboratories from not only all over the United States, but all over the world. And there are definitely differences in the assays that individuals use or individual laboratories use, and differences in the way that they measure the analytes and perform the tests. That doesn't so much limit what we can, conclude from our study, but it does limit, the statistical power of our study in that there are some individuals with 20 amino acids measured and others with 50, and it's difficult to make one-to-one conclusions based upon those differences. And then lastly, it's very important to note that we didn't incorporate any information on the patient's nutritional status or supplementation at the time of testing, either at baseline or at crisis. And that's information we're actively trying to collect from patients like yourselves as we move forward. That's very important for us because if, for example, if we know that someone is fasting, then we, use that lens to look at their testing differently than if someone is on their baseline formula or nutrition. And so that's one of the things that was a drawback here, but that we're actively trying to address as we move forward. So in terms of our next steps, we're continuing to collect data and build up our numbers to get more, statistical significance and get a greater power to our study. We do want to perform additional analyses comparing our TANGO2 patients with healthy age-matched controls, and that's something we're actively working towards. We want to perform additional, more sophisticated analysis, trying to correlate the severity of crises with metabolic abnormalities. So using a marker like creatinine kinase or CK levels or lactate levels to tell us, does that predict how severe their crises are and how does that correlate with the abnormalities that we see in their plasma amino acids or urine organic acids, et cetera. We also want to examine other metabolic testing being collected to see if that adds any other clues to the potential biochemical signature of this disorder. So we gratefully have data from urine amino acids, specific enzyme analyses that you guys have provided, and that's been really helpful. And we're working towards trying to incorporate that into our analysis moving forward. So with that, I want to extend a great thank you to all of the patients who participated in natural history study and shared their metabolic data with our team. We could not do this without you, and we hope that you continue sharing your data and being part of this study moving forward. I'd like to thank my collaborator or my partner in this study, Dr. Claudia Soler Alfonso, and we're both happy to answer any questions you guys may have about this work, and I look forward to hearing from you in the future. Thank you.